This is a discussion of the state of the science on treatment adherence and symptom reporting and management in prostate cancer. This is Sandra Spoelstra, an associate professor and fellow in the American Academy of Nursing. First, I'd like to acknowledge and disclose I have had several mentors over the time, so I acknowledge them. Drs. Given and Sikorsky, Dr. McCorkle and Haria, Drs. Champion, Rawl, Northhouse, Bernie Simprich, and Ellen Smith. And I'd also like to acknowledge my new collaborators, Dr. Philippa Jones and Verna Lavender from the UK ONS. And of course, Dr. Michael Moyani from the Winston Churchill Memorial Trust Foundation. I have no disclosures to report. I've had several funding mechanisms over a long period of time regarding my cancer research, and here is the entire list. The objectives of this presentation is to review the state of the science on adherence to oral agent treatment and symptom management reporting and management, and then to relate the state of the science to care of those with prostate cancer. So why fund behavioral intervention research if the interventions found effective are not adopted into practice? It's a really good question. So let's talk about the problem first. So oral anti-cancer agents are the best treatment for many types of cancer, and they're used for prevention of prostate cancer, during active prostate cancer treatment, and for advanced prostate cancer treatment. Oral agents require patient self-management of symptoms from side effects and adherence. Patients may experience symptoms and miss as much as 1/3 of oral agent doses. So adherence to treatment and symptom management and reporting is complex, multi-component, and challenging, both for the patients and for the clinicians that care for them. So I'm going to tell you a little bit about my prior work. In my first trial, it was an automated voice response study, and findings were that patients are assumed to be motivated to take their oral agents and self-manage their symptoms, but motivation should not be assumed. The AVR was feasible both for symptom management and use of a toolkit, as a nursing intervention, and to improve adherence to the oral agents and to manage symptoms. In my second trial, I used the automated voice response to manage the symptoms and adherence, and here are the findings from a 3-arm, which was AVR alone, AVR to manage symptoms and adherence, or the AVR with RN-directed strategies to manage adherence via the phone, plus, of course, a toolkit, because I always use a toolkit to manage symptoms and adherence. We found 42% of the patients were not adherent, and missed doses increased with the regimen complexity. Symptom severity declined over time in all the groups, but there was no difference in adherence rates among the intervention arm groups. We did have higher adherence rates related to lower levels of symptom severity, but that's kind of something that would seem logical. And the AVR alone was just as effective as the AVR plus the RN calls to promote adherence and manage symptoms. So in sum, it seemed like the technology worked really well and it was cost effective. Then in trial 3, I felt the need to look at how patients attributed their symptoms. So the symptoms are similar in oral agents to those experienced by many of the IV chemotherapy patients, and those with comorbidities attribute their symptoms to cancer and comorbidity both. We also asked some questions about actions taken by the patients, and we found they did not call their clinicians very often. And when they did call, they had a high level of interference and severity. And sometimes it was moderate, but most often it was high. And often the symptoms they called about were those regarding where they could get medications, like with pain management, because they wanted a prescription for a pain med. So patients preferred written symptom management information to supplement their verbal communication with clinicians so they could refer back to it when they needed. And not all the patients were provided symptom management strategies in writing, but when they had it in writing, they chose to use it. So all patients with oral agents experienced interference with other comorbid conditions, and the level of interference between the cancer treatment side effects and the comorbidities was moderate to high. So this study informed a lot of my future work. In my next two trials, I examined a text messaging intervention and found that text messages improved both symptom management and medication adherence among cancer patients prescribed the oral agents. It was a preliminary efficacy study, and I found higher rates of adherence with an effect size of 0.62 and fewer symptoms with an effect size of 0.5. So we established proof of concept and preliminary efficacy of text messages to promote both symptom management and medication adherence for oral agents. And we also found that most patients read their text messages, and most had very high satisfaction with the interventions. But please note, there's nothing here in regard to reporting of the symptoms to clinicians. And then I felt the need to conduct a literature review. In one meta-analysis, it found medication adherence interventions were effective when they focused on the patient factors like their knowledge, motivation, and behaviors, on symptom management, and then on administration of the medication like the timing, the dosing, and the complexity. We also found that patient education alone was rarely successful, but improvement in adherence was found when it was combined with behavioral interventions. And when using cognitive behavioral therapy specific, there was a 48% improvement in medication adherence. And this was best when the CBT was done with face-to-face contacts. Also evident was that when toolkits that were evidence-based were used to manage symptoms, self-manage the symptoms, it was highly effective. So a body of literature indicates motivational interviewing was also effective. So after this review, I felt the need to attempt to combine patient education, cognitive behavioral therapy, and motivational interviewing in one single intervention. So that led to targeting certain domains. So for the informational component, we targeted the cognitive domain, which was providing the knowledge and patient education to support behavior changes. And then in the motivational component, we targeted the affective domain, which allowed the opportunity for developing a favorable attitude towards managing symptoms and adherence, and then also capitalizing on their own internal self-efficacy. So we chose to use motivational interviewing to enhance the motivation because we found the majority of pharmacists are trained in MI. Also, we identified barriers and effective strategies to overcome limitations to serve to enhance the motivation. And then finally, we used behavior component targets to target the domain of the psychomotor. Through repeated instruction, like 1 face-to-face and 3 phone sessions using cognitive behavioral therapy, we felt as if the skills were required to maintain behavior change and simply to use strategies to manage symptoms and adherence. So this led to our trial 6, which we called Adhere, and utilized nurse practitioners. It was a randomized control trial where we had combined the motivational interviewing, cognitive behavioral therapy, and patient education, and it was provided by nurse practitioners at the start of oral agent treatment. They educated patients face-to-face to self-manage their symptoms and adhere to their oral agent, and then after that they followed up with 3 weekly phone calls to assure they were on track. We found those that received this intervention had lower symptom severity, and reported adherence was at a much higher rate, although it didn't differ by groups. Patients were highly satisfied with the Adhere intervention, and we found Adhere was feasible for standardizing clinical practice for patients on oral agents, and it was highly generalizable and transformed cancer care for people prescribed oral agents. And because it was funded by the Oncology Nursing Society, they recommended that no further testing occur and it become the new standard of care, which was then established by the Oncology Nursing Society by publications and multiple presentations at specific venues to disseminate widely across the state, across the country and world. It's had very high uptake and is now the basic standard of care for those prescribed oral agents. I also had a visitor from the Winston Churchill Memorial Trust, fellow Dr. Michael Mahaney, who was at that time a PhD student at Oxford Brookes University and a senior nurse manager at York Teaching Hospital NHS. He had 5 recommendations for the NHS in the UK after his visit with me in the US here, to implement a model of care with the RN or pharmacist providing education to patients newly prescribed oral agents, kind of like what I just described in the Adhere intervention. And then to adapt care based on the type of oral agent that's prescribed, and to implement it with clinical nurse specialists, and to provide a tool to patients to self-assess symptoms from side effects, and to use technology to enhance patient care when possible. And when he was visiting me in the US, he explained how the 24-hour triage system worked in the UK and connected me with UK ONS members Dr. Verna Lavender and Philippa Jones. After that, I examined the 24-hour triage as a potential solution for symptom management and reporting here in the US, and found that Dr. Lavender and Jones were very easy to work with and helpful. But here, there are several barriers in the US as well as in many other countries. Healthcare is fragmented, and not all settings have the skills regarding implementation of this type of an intervention, and it wasn't publicly available, although I found when I contacted Dr. Lavender and Philip Jones, they were very willing to share. So the conclusions from all of my prior work include ABR texting and nurse practitioner face-to-face and calls were all effective at promoting oral agent adherence and managing symptoms. And then when patient education, motivational interviewing, and cognitive behavioral therapy are combined to deliver interventions with a written toolkit to self-manage strategies at home, it's highly effective. I've also noticed that over the last decade, oral agent adherence rates have improved significantly. I think this is due to the use of interventions to self-manage medication taking at home and the increased dissemination of interventions like Adhere to inform patients on what to do. However, I still see several continuing gaps in care. Cancer settings are challenged to deploy and manage oral agent adherence and symptom management technology. Patient symptom reporting and self-management does not seem to have improved much. And clinicians continue to obtain late, inadequate, or no information on patient symptoms, but sometimes they simply get too much information on symptoms from patients. And there's continued difficulty with reporting and managing oral agent adherence. So what's the current state? Here's the dilemma. Patients and caregivers need to know how to assess symptoms and then make a judgment regarding those symptoms based on the assessment, then to act or not act on what they judge to be the problem with the symptom. So that means they either take immediate action on symptoms that need immediate care, like going to the ED or going to a doctor's appointment, or to simply report a symptom that needs medical or RN care via phone because maybe they need a prescription, or choosing not to report symptoms because they can self-manage it at home because it's not severe enough to warrant medical attention. Another dilemma is that patients and caregivers remain reluctant to call busy oncology offices or departments. And they're also uncertain when to call the oncology office or department. Another dilemma is that clinicians do not speak the same language as patients or caregivers, and two-way communication is challenging. Another dilemma is that clinicians are challenged to manage the high volume of calls from patients or caregivers that need immediate attention, but it's not immediate, that needs to be reported with no action, or doesn't need to be reported at all because it can be self-managed. So callbacks to patients and caregivers often lag behind the need, which can lead to an ED visit or hospitalization, and always to decreased patient and caregiver satisfaction. Another dilemma is that not all oncology practices have a team to manage patients' prescribed oral agents, and therefore may not keep up to date on medication side effects by disease or medication. And finally, adherence reporting to oncology offices or departments remains a problem. In essence, you simply don't know what the adherence rate is. So what are some probable solutions to these challenging dilemmas? To utilize implementation science to embed evidence-based practice interventions into practice to address these dilemmas. However, there's no magic bullet just to simply make this happen just because you want to. So evidence-based practice elements like the 24-hour triage rapid assessment and access toolkit, or a model of care with an RN or pharmacist providing education to patients' newly prescribed oral agents, like our Adhere intervention, or utilizing medication adherence reporting and management interventions, or technology like telemedicine, cell phones, texting, email, websites, and others are all evidence-based practice elements that may be needed to support oral agent adherence and reporting and management of symptoms from side effects of these types of treatment. However, implementing evidence into practice can be very challenging. For example, what do you include in the implementation plan? Success of implementation of these types of interventions requires addressing multiple factors. You have to think about what is the current state of the organization by assessing it to identify barriers to implementation, and then linking barriers to behavior change techniques at the individual level and implementation strategies at the organizational level help. And you also have to think about to whom are you implementing the evidence with. You need a lot of knowledge about your audience, and multiple audiences often require multiple strategies. And then, what evidence should be implemented into practice? Evidence synthesis over a body of literature rather than a single study is always recommended. And you also have to decide on clinician behavior change strategies in addition to patient behavior change strategies. So also you think about what strategies should be used. Designing implementation from strategies that are broad and techniques that are micro. But we do know that multifaceted intervention implementation strategies are more effective than single strategies. So as you can see, implementing evidence, like shown on the prior slide, into practice can be challenging. You need to have a plan, know the current state of the organization, to whom you're implementing the evidence with, what evidence should be implemented, and what strategies to use to implement. You also have to know that not all strategies to implement evidence are equal. As shown here, the most effective is local opinion leaders at 12%. And next is educational meetings or educational outreach at 6%. Printed educational materials, audit and feedback, and computerized reminders are also effective. Basically, you can see, as shown here in these effect sizes, you need multiple strategies to implement these types of interventions in cancer care. The expert recommendations for implementing change, known as ERIC, has a evidence-based list of implementation strategies that they recommend from multiple research studies that can be used at the macro and micro level in organizations to support implementing interventions as discussed in this presentation. They also have a tool to select which strategies fit the setting. It's good to know when you're making practice improvements that you need to think about the context, actions, mechanisms, and outcomes. Here's a list of actions that need to be taken when you're starting out with practice improvement. Identify the problem, identify a goal and objectives, and develop a team to address these problems or issues. Conduct an assessment of the organization and its strengths, weaknesses, opportunities, and threat identification. Gather and analyze baseline data and identify evidence from the literature that fits the context. Develop a detailed plan with implementation strategies, measures, and a way to analyze them. And then provide training and education, facilitation and coaching to the clinicians so they know what to do. And developing stakeholders and champions are great ways to implement improvement in practice. Then once you implement the intervention or interventions, you do auditing and provide feedback ongoing so that people know if there's improvement or not, and always analyze the findings of improvement in practice so you can share it with others. Whenever you think about what the context in, it's both the setting and the participants. So a setting could be an oncology office, a hospital, an ED department, or even maybe partly the payment system, how all of this is paid for. And also, who are you working with on the practice improvement? It's almost always patients and or caregivers and clinicians. And then it's good to know what mechanisms increase uptake. The current literature shows that interest, confidence, uncertainty, commitment, trust, awareness, and satisfaction are all mechanisms that improve uptake of interventions. And always evaluate your outcomes so that you know if your goal and objectives are met, and that your measures and indicators are objective and that they're attained, and that you can see financial resources are saved, or what it costs to provide interventions. It also helps you know if your intervention is sustained and institutionalized within an organization. So let's think a little bit about prostate cancer. According to the National Cancer Institute, 7 types of standard treatment are used for prostate cancer currently. Watchful waiting or active surveillance, surgery, radiation therapy and pharmaceutical therapy, hormone therapy, chemotherapy, immunotherapy, and bisphosphonates therapy. 4 of the 7 treatments include oral agents of some type. So for care of those with prostate cancer, as well as other types of cancer, within the context or setting of the practice, hospital, and with patients and caregivers and clinicians, these 4 elements seem to be highly effective and are all evidence-based. The 24-hour triage rapid assessment and access tool, along with a model of care by a RN or pharmacist providing education to patients newly prescribed oral agents like the Adhere intervention, and utilizing medication adherence reporting and management interventions supported by technology. It's a very multimodal, multi-component practice improvement list of evidence-based interventions that are needed to care for those who are taking oral agents with prostate cancer. So, in summary, over the past decade, oral agent adherence has improved. Side effect symptom reporting and management has improved slightly, but it's not where we want it to be. And a great need remains to improve both, particularly in those with prostate cancer. So effective evidence-based interventions to report and manage oral agent adherence and symptoms exist, yet are underutilized, and implementation science can guide use and improvement in cancer care. Here are the references for this presentation, and I provided my contact information if you would like to ask me any questions in regard to this presentation or simply want to email me and talk about oral agent adherence or symptom management. Thank you so much for inviting me.